Good evening, my colleagues. In the field of anesthesia and intensive care, we are welcoming you tonight to attend a very beneficial meeting with Dr. Adel Hussein. Dr. Adel Hussein is a well-known consultant of intensive care in King Abdullah Medical City in Makkah, and he is an eminent intensivist. He introduced many lectures for us in the last few months related to the topics and very important in the ICU to management critical care. Dr. Adel last time, he introduced the scenarios for difficult cases of intensive care, and our colleagues shared us in the discussion of these cases. And today or tonight, he will introduce the way how to deal with MCQ that you will be confronted with in the examination regards the intensive care certification, whether it is in intensive care, European intensive care, or even in anesthesia and ICU for MED, or even for your professionalism in your career as an intensivist or anesthetist. You're welcome, Dr. Adel.
Thanks a lot, Dr. Talat, for your nice introduction. And thanks, Professor Saad Mahdi, for inviting me tonight and giving me the honor to be with you, the panelists, and our colleagues who attended the webinar tonight. And thanks a lot for the organizing committee and the head and shoulders behind this huge educational online work through the mega learning platform. بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الله المرسلين سيدنا محمد صلى الله عليه وسلم. Tonight, as we promised before, this is one of the modules that we are preparing our colleagues dealing with adult critical care medicine, preparing themselves for the certification or the exams of the critical care or adult critical care medicine, or anesthesia and critical care medicine as well, including the critical care board, the critical care fellowship, the critical care master degree, also MD degree, the EDIC and EDIAC. So it's intended for all candidates who are dealing with the MCQs through their exams. If you remember, the last month in August, we presented the webinar for acute pulmonary embolism, and one of the days, it was 3 days webinar. One of those days, it was an OSCE session. This is one module that, inshallah ta'ala, with the next few months, we will go through according to the timeline from Professor Saad. When the chance allow, we will present further OSCE. Tonight, we will present a different module, which is the MCQ, and this will be an interactive session, the same we presented in the OSCE. But let's, to remind you before we start tonight interactive session, as we mentioned, it's interactive session. So we need contribution from our attendees and our colleagues who attended or who are preparing themselves. So at the end, it's not an exam. We are not giving a score by the end. It's an interactive session. So I'm learning. I will not say you are learning, but you will get some information, maybe the same information you have, or a new information for you, or a homework you have to go back and to review this topic. And this is the idea behind those interactive sessions in the coming months. Just sometimes you are dealing with the MCQ in a case scenario. Maybe it's a practical scenario, but the evidence-based, it was updated, so you are not aware, or something you are, you know about it, but there is some numbers, some statistics some details you miss it through your reviewing or through your revision of this topic. So this is the idea behind the interactive. So I need to test your skills tonight and the further sessions. And the more you interact, the more you gain, the more you contribute, and the more you add to me, that I will be grateful and thankful that we did something at least with each session. So remember, again, it's an interactive session. So I need volunteers, I need contribution. So for each question, we need volunteer. The volunteer will drop his name on the chat box, or he will raise his hand. So Dr. Talat, he will choose the candidate, and he will ask him to unmute himself or herself. Then he will read the question, he will answer. I will give him a total of 5 minutes to read carefully and to answer the question. And I will be grateful if he can give me some rationale for his answer. I will not interrupt him. By 5 minutes, I will stop him. Then I will move for the question answer. So each question will be followed by 4. Number 1 will be, I will provide the correct answer. Number 2, I will provide the rationale for the answer. So it will tell you why I'm right, why I'm wrong. Then I will follow by some teaching points. I will not review comprehensively the topic, but just I will highlight important teaching points. You can call it take-home messages. Some hints, some summary about this topic in particularly. I will end also by some references. So if you can review the presentation back at home at any time or at ease on the YouTube channel or on the website for the Mega Learning platform, so you can have the chance to review those references as a background for the topic. Also, I will end up the presentation tonight by homeworks for you that we presented, like 2 or 3 or 4 topics, whatever the time allow us. Then those homework, you have to go back and to read it carefully, preparing yourself for the exam. So now you have the background, you have the topic, you have the references, and the MCQ. This is considered as an important homework, so you should not miss. And by this way, you may have the curriculum by the end of those sessions, whatever the number. So you have a curriculum in your hand, answered, referenced, rationalized with teaching points. So let's start with the first question or the first MCQ. Dr. Talat, I need a volunteer.
Yes, Dr. Adel.
I need one volunteer to drop his name on the chat. Then you can ask him to unmute himself. Then he can answer. And I will give him 5 minutes. Then I will provide the answer and the rationale and the teaching points and the reference.
Right. The message is to all our respected attendees, especially who are working in the field of intensive care. And there is no problem for the anesthetist also to share, because our study involving intensive care anesthesia during our post-graduation also. So I don't want to choose one per se, and if anyone can raise his hand to share us the discussion and to communicate with Dr. Adel Hussein in the discussion of the questions and interact. We have many attendees. So may I choose one?
So Dr. Ahmed Magdi, he raised his hand.
Yeah, you're welcome, Dr. Ahmed. You can just open your microphone, Dr. Ahmed, to share us.
Is it allowed to talk now? Dr. Ahmed, yeah. Allowed to talk? Okay. Dr. Ahmed, are you okay?
Hello, Assalamu alaikum.
Alaikum
salam
salam.
wa barakatuh.
Thank you, Dr. Ahmed, for sharing us.
Thank you, Doctor. I will start to read, or
Yes,
I will take 5 minutes.
Dr.
first?
Ahmed, I will give you 5 minutes from now. I will not interrupt you. So
Okay.
the scene for you.
Okay, thank you.
Dr. Ahmed, you can read loudly the question.
Okay.
It would be better for our colleagues also to listen.
Okay. A 55-year-old woman with a history of diabetes, hypertension, and coronary heart disease is admitted with ST elevation myocardial infarction. She undergoes emergent cardiac catheterization and stenting of the left anterior descending artery and circumflex arteries, followed by an intra-aortic balloon pump replacement. On day 2 of admission, her blood urea nitrogen and creatinine increases from 10 and 1 and 1.5 respectively, with a decrease in urine output. Upon examination, legs are mottled and
So, Dr. Ahmed, you will have 5 minutes, as Dr. Adel said. Then you can read the questions.
Dr. Ahmed? Dr. Ahmed?
So he sees that he's gone.
Okay. Any other volunteers? I saw some hands were raised.
Yeah, Muhammad Shad. Yeah, okay.
Yes.
So Muhammad, you can unmute yourself. Okay, you can talk now.
Assalamu alaikum.
Hussein.
عليكم السلام ورحمة الله وبركاته.
Yeah, Dr. Muhammad Shad.
أيوة مع حضرتك.
You're welcome, Dr. Muhammad.
أهلا وسهلا.
I think you have listened to our colleague before he read the paragraph of the question, or you want to read it again?
Yes, I just read the question. It's okay, fine. I can go ahead.
Okay, Dr. Adel, you can go ahead to the question.
Okay.
So, what is the cause of her acute kidney injury? I think the answer is A. Cholesterol emboli causing tubular obstruction and arterial tubular necrosis. I think this is what's called post-intervention emboli that could occur after the insertion of the aortic balloon. What can just enhance my choice is the peripheral finding, the skin peripheral finding that can be the cause of the small emboli that obstructing the small vessels, including the renal vessels and the peripheral vessels and the lower extremities and maybe the upper extremities.
So your choice is
my choice is A. My choice
A.
is A. B, it could be the correct answer, the choice B, but I don't have enough information about the hemodynamic changes in the question. So it's not discussed or if the patient was hemodynamic stable or not. So I will go with the choice A.
I think, Dr. Adel, if there is hemodynamic changes or the patient gets shocked or a need for inotropes or vasopressors, it will be mentioned in the scenario, right? So forget about that.
Okay.
Just consider that the hemodynamics was okay. Or if Dr. Adel can give the core of the question.
Right. Agree with you, Dr. Talat. So according to Dr. Mohammed Saad, he chose A based on the scenario, but in the scenario, the patient has PCI for her coronary artery disease toe vessel plus intra-aortic balloon. So usually we put intra-aortic balloon for hemodynamically stable STEMI, or what do you think, Dr. Mohammed Saad?
Yes, I agree with you. I agree with you. But I think that after the replacement of the intra-aortic balloon pump, with the conjunction of the another history, another diseases like diabetes, hypertension, and the patient has, I think it had atherosclerosis or it had high cholesterol.
I agree with you, but you highlighted one important thing is regarding the hemodynamic profile, is stable or unstable. So in the scenario that it was followed by intra-aortic balloon. So what do you think? It's STEMI complicated by cardiogenic shock, or just for chronic? Sorry, for the PCI only.
It's difficult to say that, but I think that the time in the day 2 of the admission, the change of the blood urea and the creatinine plus the skin changes. So usually the skin changes occurs within minutes or hours in the shock status. So that's occurred 2 days after.
Okay. So according to your answer rationale that you choose A because of the skin changes, you did not choose B because the scenario did not mention the hemodynamic profile or the hemodynamic status, though the patient was supported by intra-aortic balloon. Third, you did not choose C, contrast-induced nephropathy, though the patient received the contrast for the diagnostic coronary angio and PCI. Why not CIN?
So yes, I'm with you. Unfortunately, I cannot answer this question.
Okay, what about cardiorenal syndrome? Answer D.
That could be the cause to
her AKI. Why D is wrong, and why E is wrong? And why not is contrast-induced nephropathy? Why not is cardiorenal syndrome? Why not urinary obstructive uropathy?
So urinary obstruction, I can exclude the urinary obstruction because then the renal, the labor was normal before this this scenario. So a urinary obstruction is not yes in my mind. I think it's not the correct answer. So the patient has renal problems after a cardiac event. So the answer E is not probably the correct answer. Urinary obstruction.
So now, what's your final thought and the correct answer in your opinion after you revise yourself now? Is it A, B, C, D, or E?
I think it's A. I think it's A.
A.
It's a post intervention emboli causing renal failure and peripheral manifestation after initiation of aortic balloon.
But you did not convince me about C. Why C is wrong? Or not the correct answer. You did not give me a rationale for your exclusion of the CIN, right?
It's not mentioned that the patient undergoes a contracts metal.
No. She received already. She did stenting, and it was mentioned clearly. She had STEMI, she undergo emergent cardiac catheterization and stenting. So she received the contrast.
Yes, that's right. I think that the contrast metal today's are safe more than before, but that can the cause. It's difficult to say that it's not the correct answer. It could be the correct answer. It could be B, C, or D2. So for me, I cannot say 100% that C is false or true.
So if I will ask you to for this scenario, now you choose A, and I will ask you if to put 3 common causes among those 5 in priority. Number 1, then number 2, number 3. As a differential diagnosis in her AKI, the reason for AKI in this patient. Number 1 is most likely, and number 2 could be, number 3 less likely.
As differential diagnosis, I can say number 1, it
Top
could
3.
be
Top 3.
or 3. I will say
Dr. Mohammed, top 3, only 3.
Top 3. The first one is a renal failure, acute renal failure because of acute hemodynamic changes. If the patient was in shock.
No, Dr. Mohammed, in this scenario, among those 5, the cholesterol implied, the ischemic ATN, the contrast nephropathy, cardiorenal syndrome, urinary obstruction. The top 3.
The top 3, I think the choice is A, B, and D.
A, cholesterol imply, the top, then?
So you want to say what are the top in this question or in general?
In this question.
In this question, I will say A, then B, then D.
A, B, and D. While contrast-induced nephropathy is not common in this patient.
It could be the last differential diagnosis that I think about.
So in this patient, Dr. Mohammed, the cardiorenal syndrome is commoner than the CIN in this scenario?
In this scenario, I think no. I think the contrast metal induced nephropathy is commoner than cardiorenal syndrome.
Dr. Adel, can we listen to our colleague Ilona? She's our colleague Ilona. She wants to answer. Ilona, can you speak now? She might have something to add to us. One of our colleagues.
Okay, Dr. Sa. Okay.
Thank you so much. Ilona? Hello? Hello, Ilona? I don't know if she gone or if she's still here.
I'm still there.
Okay. She seems as not here. Anyway.
I think Dr. Saad, she raised her hand at the start.
Okay, she's here now. Hello, Elena? Okay, we want to give a chance to everybody. Okay, thank you so much. Okay, Dr. Mohammed, thank you.
Thank you very much.
Okay, Dr. Adel, I think Dr. Mohammed shared his answer as he said A, B, and D, and C will be the last probability for the answer of the question.
Thank you, Dr. Talat. Thank you, Dr. Mohammed Saad, for your positive interaction and contribution. And this is what we would like to have in our interactive session. And as I mentioned, the idea behind the MCQ. Of course, during the exam, we have a load of MCQs like 100 or 120 or 150 according to the policy or the plan of the MCQ of this exam. And we will not have this time, but this is how we are learning when we choose by rationale, which is the most accurate or the most correct answer. Then I can prioritization issue is I will put like the top 3, then two, then the most likely will go through. So Dr. Muhammad Saad, he chose the cholesterol imply causing ATN or acute tubular necrosis and AKI as the most common cause of AKI in this patient, but he did not choose the ischemic ATN, and he did not choose the contrast in this nephropathy, and he did not choose the cardiorenal syndrome, and he did not choose urinary obstruction. He was thinking about the hemodynamic status of this patient. So we told him that patient is already on intra-aortic balloon, so probably she's in cardiogenic shock. He missed that the patient received contrast, though the patient had already diagnostic angio, coronary angio, and stenting, which is BCI for 2 vessels. So the patient already received, and she's at a risk of CIN, or we can call it high risk. Why? Because patient is already diabetic, hypertensive, and she has ischemic heart disease and shock state. So she's a high risk for CIN. For cardiorenal syndrome, he gave me a rationale why he did not choose, and urinary obstruction as well. So thanks again for Dr. Muhammad Saad. So we will go for giving you the correct answer, which was, as Dr. Muhammad Saad mentioned, it's A, which is the cholesterol emboli causing tubular obstruction and ETN. So thanks, Dr. Muhammad. Dr. Talat, can I go back to Dr. Muhammad to ask him one question in the scenario?
Yes, Dr. Muhammad, you are still with us? Dr. Muhammad Saad?
Yeah, I'm there. I'm there.
Dr. Muhammad, thanks a lot. I'm very grateful and appreciating your correct answer. Just one small question. From those 2 pictures I provided in the scenario, do you know what's the sign or what's the finding of this peripheral or skin changes or skin mottling? Do you know the name of this finding, physical finding of skin mottling? It has a particular name. Do you know, you have an idea about it?
That's right. There's a particular name, but it's not in my mind now. I cannot remember the name exactly.
Thanks a lot. Thanks a lot.
Yeah.
So this is the correct answer, as Dr. Muhammad Saad mentioned. Now we will go through dissecting the rationale, and then I will give you some teaching points, and we'll end up why some reference. So the rationale for our correct answer in this scenario, which is the cholesterol emboli causing acute kidney injury, based on the scenario and the skin finding in those pictures that we provided, and these are the clue of the correct answer. This skin finding called levido reticularis. So this is a levido reticularis. Remember this one, or this physical finding, we call it levido reticularis. This is secondary to cholesterol emboli. This patient has vascular manipulation, as we mentioned. First, we started with coronary angio, then BCI, then intra-aortic balloon. And those are procedures or manipulations dealing with arterial cannulation and arterial procedures ended up by intra-aortic balloon insertion. Her AKI here, why this patient developed AKI, though they started with normal BUN and creatinine. So the baseline of this patient has normal renal profile. So based on the scenario, based on the skin finding, the AKI is likely due to what we call it cholesterol emboli. This cholesterol emboli, it causes some ischemic changes at the periphery, renal tubules, and will lead to ATN. I will tell you in the teaching points what about those cholesterol emboli, and the pathophysiology, actually it's behind the cholesterol embolization syndrome. It's mainly because of plaque rupture. So those plaque rupture in medium-sized artery, it will be embolized after the manipulation. So basically we have atherosclerosis, we have atherosclerotic plaque, then we have manipulation like a catheter insertion or aortic balloon, and or for example VAA ECMO. Then it will end up by plaque rupture and peripheral embolization. And this peripheral embolization can go systemically, can go to renal, can go retinal, can go CNS, or can go to the GI systemic circulation. So in this patient developed livido-reticularis, skin changes, and AKI. If you ask me, when we provide the two pictures of this skin mottling and changes, this we call it livido-reticularis. So the livido-reticularis or the skin changes are absent in the ischemic ATN if this patient is cardiogenic shock. So usually the ischemic changes is not associated with the ischemic ATN or AKI related to hypotension, not also absent in contrast-induced nephropathy or AKI due to contrast-induced nephropathy, cardiorenal syndrome, and urinary obstruction. Of course, renal obstruction will not cause skin changes, and the renal chemistry or the renal profile may take some time to be raised, and we should have a clue for the urinary obstruction. But here we have three, as Dr. Muhammad said. I will choose top three is the cholesterol emboli. I will choose ischemic ATN if this patient was in cardiogenic shock. I will choose also contrast-induced nephropathy because this patient, she received contrast. I will not choose CRS or cardiorenal syndrome. I will not choose urinary obstruction. If I want to minimize my choices to the most correct, based on the scenario, and this is the clue, is the skin finding or the skin mottling, which is, we call it livido-reticularis. This is specific for cholesterol emboli. So I will choose cholesterol emboli. Let's go with some teaching point regarding the cholesterol emboli and the livido-reticularis. The incidence of cholesterol emboli in patients who underwent intravascular procedures, like in our scenario, PCI or percutaneous coronary intervention or stenting, has been reported to vary between 0.6 to 0.9. Still rare, but you should put in your mind, especially in elderly patients who have atherosclerosis, do have multiple arterial manipulations, as we mentioned, like PCI, diagnostic coronary angio, intra-aortic balloon, VA ECMO. So those patients are a high risk for plaque ruptures. The skin changes, which we call it livido-reticularis, is a cutaneous sign or cutaneous physical sign characterized by transient or permanent or persistent, blotchy, reddish, blue to purple. So it's between reddish blue to purple. It's net-like cyanotic pattern. So here is the picture. This is the correct description. Net-like. Here it's all over the skin, and here is the sole, the toes, and you can go for the abdomen as well. So this is what we call it, libido reticularis, net-like cyanotic pattern. This libido reticularis has been described in almost about 80 to 88% of cholesterol emboli. So you may find cholesterol embolization syndrome without libido reticularis in about 10 to 12%. But the commonest reason or cause of libido reticularis is the cholesterol emboli. Libido reticularis is an inflammatory, as I mentioned, inflammatory process with inflammatory pro-markers, mainly interleukin-5, activated by T cells. And this inflammatory cascade initiated by, as I mentioned, plaque rupture. So once you have a plaque rupture, the cascade starts and it will end up by vasoconstriction, mainly in the medium-sized or small arterioles. As I mentioned, it will end up by the skin finding, ending up sometimes by retinal artery occlusion, CNS stroke, or lower limb ischemia or gut ischemia. Some reports of increased survival or improved outcome and the renal function after giving some steroids. It's not an evidence-based so far. We don't have a randomized control trials to support this strategy, but if you go back to the reported cases of cholesterol emboli, there is some survival and some reversal of the renal function or recovery of the renal function after giving IV steroids for 5 to 7 days. If you need to have some references, those are 4 references, updated references from 2010, ending up by March 2022 this year, about the cholesterol embolization syndrome and the libido reticularis. So you can have a review through those references. So I encourage everyone who need to know about the cholesterol embolization syndrome and libido reticularis to review those references. Now I will move to question number 2, Dr. Talat. So I need
Yes.
one of our volunteers,
Dr. Adel,
rather than Dr. Mohammed Saad.
From my side, Dr. Adel, after you finish the rationale for the question in an excellent way, and the other choices that you mentioned, one which is very common, as long as the skin mottling are not there, which is CIN, contrast-induced nephropathy. Just in short, in 1 or 2 statements, the best management for a patient who got contrast-induced nephropathy for our colleagues also, because there is a debate for the N-acetylcysteine and vasodilators.
Thanks, Dr. Talat, for this important question. As Dr. Talat mentioned, that we face the CIN or the contrast-induced nephropathy in ICU patients because of the wide spectrum and the heterogeneous risk factors like the age, the comorbidities, mainly diabetes, hypertension, atherosclerosis, the baseline kidney function, and the hemodynamic profile, shock state. So we have heterogeneous risk factors. So the best management or the latest evidence base of contrast-induced nephropathy is the prevention. So to prevent is better than to treat. There is no definitive treatment for CIN except for observation or dialysis. That's the mainstay in the treatment. But the mainstay is to prevent the CIN. So first of all is to identify patients who are at risk, as we mentioned. So you screen those patients who are at risk of CIN, who the age, the gender, the diabetes, the hypertension, the baseline kidney function, the hemodynamic profile. And if you are obliged to do it, and you estimate the risk, so the only proved evidence-based preventive tool is the IV hydration before and to continue for 12 hours post, 6 to 12 hour post the contrast. So this is the only tool now that we have that it was evidence-based preventive tool for CIN is the IV hydration, mainly with lactate ringer or buffer solution, not normal saline, because of the hypochloremic metabolic acidosis. So this is the only way. You start usually 6 hours before giving the contrast, second to continue 6 to 12 hours post contrast exposure. What about what we have been giving in the past is the Mecomest or N-acetylcysteine, oral or IV. What about alkalization of the urine? Evidence-based, there's no benefit behind using both. So there is no rule now for a couple of years now, based on randomized control trial and guidelines, that they are not recommending to use both the alkalization of urine and N-acetylcysteine or Mecomest. They are adding no benefit at all for prevention, only screening for risk factors and IV hydration.
Thank you so much. We can proceed for the next question.